Good afternoon, everyone. My PhD topic is perioperative management and critical care for patients with liver dysfunction. My name is Turan, and I'm working in the Semmelweis University Department of Anesthesiology and Intensive Therapy. I have been working on 3 different projects, and all of these 3 projects are fitting onto a logical framework of what we are doing here in the Translational Medicine Center. So in general, medical research starts from observing the patients and creating policies and protocols, and then repeating the process until we get the maximal efficiency. So my first project started with looking at policies and protocols, and we asked, do the recommendations of a protocolized guideline work in practice? This was study number 1. Then we looked at existing research and trials and we asked, how do we optimize and protocolize a novel intervention? This was our study number 2. And our last study was looking at patients. And we asked, how should we approach high-risk patients with a poorly understood disease? And this was our study number 3. All of the studies are concerned with management of liver diseases. As we all know from medical school, every time we're talking about medication, inflammation, organ failure, hemostasis, we always say, oh yes, and there is also a liver aspect to it. We give a drug, it metabolizes in the liver. There is a coagulation problem, it has a reflection on the liver. Now the problem is, how do all of those other things are affected when the liver is the problem? And this is why this is a fascinating topic for me. My first study is the effect of preoperative administration of glucocorticoids on the postoperative complication rate in liver surgeries. Now, liver surgeries are still quite dangerous. Mortality rates can reach up to 20%. And the hypothesis is that the underlying cause is maybe operative stress, maybe injury to liver parenchyma, but more and more we have been thinking about a dysregulated immune response which happens in liver patients, which causes systemic problems. So what can be a solution? Why don't we modulate the immune response? And steroids are ubiquitously available drugs. The premise of this whole study was in the 2016 Enhanced Recovery After Surgery Society guidelines, preoperative administration of glucocorticoids to protect the patients was recommended weekly with moderate level of evidence. 4 meta-analyses have been done in the past, with the last one, 2021, finding, there is a statistical significance, let's put this in clinical practice. But since then, 3 new RCTs came up with 400 new patients, which doubled the entire sample population for this research question. So our aim was to reproduce guideline-informing research in the light of this new evidence. We performed our systematic search twice, because the first one on 2021, and then we repeated our search on 2023 to be up to date. Eventually, we ended up with 11 eligible randomized controlled trials. Our main outcome was the overall postoperative complication rate, which includes every kind of postoperative complication. Here we saw that with an odds ratio of 0.71 and a p-value of 0.23, there was no statistically significant difference, which is opposing the previous meta-analysis conclusion. But different to all the other meta-analyses in the history, we also checked other complications one by one, particularly. In none of them, we saw any significant difference between glucocorticoid and placebo groups, except for wound infection. In the wound infection group, we saw an odds ratio of 0.49 and a p-value of 0.02, which told us that there is a significant difference in developing wound infection after the surgery in the intervention group. However, for multiple reasons, we should take this conclusion with a grain of salt. Neither in the perioperative outcomes we could find any statistically significant difference between the groups. And when it comes to laboratory outcomes, we chose not to perform a meta-analysis because the reporting of the data in the literature was very heterogeneous and very poor quality. So instead, we systematically summarized our findings. In conclusion, we have to contradict the previous meta-analysis, and we have to conclude that the level of currently available evidence is not enough to draw any concrete conclusions. And the main limitation of our study was we could not do any subgroup analyses for different types of patients, which is, could be one of the most major limitations in this field. And we recommended what should future clinical trials here should look like. This manuscript has been submitted to the Acta Anesthesiologica Scandinavica, and we are waiting for a response. My second topic is about hemadsorption therapy for critically ill patients with liver dysfunction. And here, the critically ill patients sometimes develop this ICU-acquired liver injury, which can deteriorate into acute hepatic failure. And for these patients, the mortality rate can be as high as 86%. And the treatment options are more or less only limited by management of complications. But there is a novel strategy, a new technology, a relatively new technology called hemadsorption, which does cytokine absorption, it absorbs inflammatory mediators, and it reduces bilirubin and improves liver and kidney function. So here, our aim was to summarize and synthesize the available evidence to formulate different hypotheses for future trials. Again, our systematic search in 5 different databases was repeated one time, and in the end, we ended up with 30 eligible studies. Our main outcome here was the post-treatment total bilirubin levels. And here we can see that the hemadsorption therapy significantly reduced post-treatment total bilirubin level, which is an indication that this is a helpful intervention in helping the liver to adjust back to normal levels. We did not see this significant difference in creatinine, however, but then again, the evidence that is available is quite lacking. And the data from case reports and case series showed that in other outcomes we chose, like vasopressor need and ALT, AST levels, there are no significant differences, but there is possibly a tendency which should be researched further. In conclusion, hemadsorption therapy was safe to use. We did not see any device-related adverse events. The use of hemadsorption yielded a trend towards improved liver function, but the quality of clinical literature at this point is, again, insufficient, and specifically with respect to precision and comprehensiveness. So in summary, we made recommendations for future trialists to address these issues, these gaps in the existing clinical literature. This manuscript of ours is also submitted to the Nature's scientific reports. And my third project is defining the ICU-related prognostic factors in acute on chronic liver failure. Here, the problem is that recently we have realized that some patients with chronic liver disease become acutely ill because of their liver, but there is a difference. There is an acute decompensation of a chronic liver disease and an acute on chronic liver failure. And the difference between these two entities is those with ACLF have a mortality rate that can reach up to 75%. So this is an independent and different entity which we understand very, very poorly. So the missing link here is what makes ACLF so deadly? So we framed our question with a prognostic meta-analysis framework, and we are interested in checking all different risk factors and all different diagnostic criteria for acute on chronic liver failure, and we want to see which one correlates more with development of ACLF as opposed to acute decompensation and associates more with increased mortality. So we are in the beginning steps of this third project, but our aim is to identify these factors, and then with the Harvard Medical School and Semmelweis University joint research program, we wish to design a multi-center clinical trial which further investigates the results of our meta-analysis and further investigates how can we manage those risk factors which make acute on chronic liver failure so deadly. And in additional activities, I have been lucky enough to be a scientific methodology supervisor for the past year for 5 anesthesiology projects, 4 cardiology projects, 3 gynecology projects, and some others. And we also represented all of our findings in international and national conferences in the last years. I would like to thank you very much for your attention. I would be happy to answer any of your questions now. Thank you.
Thank you, Caner, your presentation. My question is related to your second topic. You showed, as I remember, 4 millimole per liter difference in the level of serum bilirubin. Mm-hmm. Is it right? Do you think, is it clinically meaningful?
It's milligram per deciliter, not millimole.
Milligram per deciliter. Yeah. Okay, but that is what we use in your daily practice? No? Okay, and what is how can we convert it?
Oh, okay, this is a mathematical question. I usually ask Google, but so basically,
okay, because
but I understand the gist of your question. What you need to realize is bilirubin here is somewhat of a surrogate outcome. When we resolve the bilirubin situation, it doesn't necessarily mean that the liver is now fine. This is an easily measurable, objectively measurable outcome, which gives us an idea about what is the metabolic status of the liver. This is not the outcome we are interested in. We want to fix the liver. And this is a marker that tells us that when this intervention is used, the liver has time to, let's say, recompensate as opposed to getting decompensation. Because in the clinical practice, what we see with these very critically ill patients with acquired liver injury is that without an intervention, the bilirubin levels exponentially increase. And again, it is not the bilirubin that's the problem. This is just a red flag that shows us that the liver is decompensating at that moment. So this is the meaning of this outcome. It's not about the numbers that directly.
Okay, thank you. So as we checked quickly, it means nearly 80 micromole per liter difference, which is, as I know in my practice, absolutely relevant. But that was tricky for me because the measure was different. Okay, thank you.
Yes. You are very right. For the next conference, I will definitely put the same units, but also in millimoles.
Thank you.
Thank you. This is a good contribution. Thanks.
I have one question for you, Caner.
Yes.
Popescu. What's the deal with Popescu here?
That's a very good question. Again, a keen observation.
Thank you.
In a regular situation, these could be the same patients, but actually Professor Popescu from Romania is a long-time, a long-time collaborator with our research group. And we made sure, even before the data extraction, we made sure that these patient populations are completely mutually exclusive.
Okay.
So we have a confirmation of that.
Okay, thank you.
What do you think? Why did you find those data that only the glucocorticoid administration lowers the odds ratio of wound infection?
Why do we think?
But what can be the mechanism behind that?
So there can be multiple explanations. One of them is it's the steroids stabilizing effect for the inflammatory markers, because usually what happens is when there is an insult in any place of the body, the liver is responsible for creating the cytokines which is going to trigger the immune response against the infection. Now, in a serious situation, it can be the immune response itself which predisposes the affected tissue to a suboptimal immune response, meaning that It can change how the perfusion in the tissue is acting, how the vasodilation in the tissue is acting, and what is the effectiveness of both blood proteins that are circulating and also the immune cells that are circulating. So those studies which found this kind of significant impact of steroid administration on wound infection hypothesize in the sense that possibly this is a stabilizing modulatory effect that lets the liver and therefore the immune system do its job without getting stuck in a chain reaction of cytokine activation. But of course, there can be other explanations, and this is actually one of the points that we are bringing up in our manuscript, that from an immunological point of view, we have found something interesting. And finally, this can also be a methodological issue. So perhaps if we had more studies with higher sample sizes, we would be able to see that actually this is not as significant as we thought. So that's why I'm saying this should not be taken at face value. This should be concentrated on and researched further.
I completely agree with you. Yes, there's a low number of patients. Okay, thank you.
For the first analysis, can you go to the primary outcome forest plot? Okay, so this is the overall complication rate. And you've said, well, there was the meta-analysis that is now outdated because there are 3 new trials, and these 3 contributed to the change of the results. Mm-hmm. Okay, where was the previous meta-analysis published?
In the World Journal of
Surgery.
I think World Journal of Surgery.
Okay. Although World, it's not really okay. And now here you said these 3 trials contributed significantly. On this forest plot, you have only 2, and both of these are more to the left. So how come then the result is now different? You see 2022 Bressan et al.
Yeah, but the Hasegawa as well.
Which one?
2019. Because
okay, this is the third one.
Yes, because when the previous team made their meta-analysis, this paper was not published, so they did not include that one. So it's actually the new papers are the Hasegawa, the Bressan, and the Stein-Torsdorf.
But all of them are more to the left than to the right, favoring glucocorticoids. And now you are saying that favoring glucocorticoids is now not favoring glucocorticoids. So where did we go wrong?
So I hope Peter won't kill me, and because I will try to give my statistical explanation for this. So a forest plot is not necessarily a combination of the direction. New evidence that is introduced into a forest plot also changes how the previous eligible papers, how the previous analyzed papers behave. So when we are doubling the number of patients that are analyzed inside the same forest plot, all those papers which previously said one thing start saying another. So that's why comparing these 2 forest plots with only taking those 3 new studies into account may not give the most clear picture.
And maybe one more thing. You're saying that Hasegawa was not in the previous report, and you said you added 3 trials. When I'm looking at what you have submitted, I see 4 trials. Hasegawa, Bressan, Stein, something, and Onoe. So yes, but, what is now?
But Onoe
only 3 contributed to primary endpoint.
Yes, because the Onoe did not report an overall postoperative rate in this way. Because the way that we here in this outcome, the way that we defined overall complication rate was each patient by patient who had a postoperative complication. In the ONOS study, they put how many people had a septic complication, how many people had a bile leakage, but all of those numbers were overlapping. So it was impossible for us, and since they didn't answer our data inquiry, it was impossible for us to determine exactly how many patients had any kind of complication and how many patients were complication-free. We only had the raw number of each class of complications that occurred. So that's why the ONOE is not here.
Okay.
I won't kill you.
Okay, thanks.
What I wanted to say, though, is how should I put this politely? Things that are published even in the prestigious World Journal of Surgery can be less correct or not using the most modern or most up-to-date methods. And in these cases, a lot goes into how we get to that diamond part. Mm-hmm. That's basically, there are a lot of methods, sort of pathways to getting to an estimate based on other, and it depends on the estimate as well. Typically, the analysis you guys get from my team is a very conservative approach. We always keep it very strict. Even here, this could be even less strict, that would still be kind of okay, and you'd be closer to a significant level. But what I always advocate for is common sense. Mm-hmm. If you guys look at this forest plot, there is one paper with 37 and 36 patients, Aldretti from 2006, that seems to support something. All the others are not. All the others are just noise around zero. Mm-hmm. So and the other thing is if you see a significant result, it still doesn't mean much, because inherently there is 5% chance that somebody made an error, or even more. But I really like the approach, that redo something that's already in the guideline and think about it. I really like that.
Thank you.
I have just one very soft question. I'm curious about your prospective study. Mm-hmm. What will be the contribution of Semmelweis University and Harvard University, and how is this study today?
You mean for the clinical trial that we would like to design? So the whole idea with the cooperation between our university and Harvard Medical School is that we will get some lectures and guidance and workshops from the clinical trialists there, and they will make sure that we are equipped with everything we need for designing a clinical trial, which actually this Translational Medicine also did. And then we will conceptualize a clinical trial with a sound background and present it at Boston. And there, if the Harvard staff enjoys the presentation and they think it's a feasible and novel idea, they will fund the clinical trial. That's the goal. But that's why before I go into this program to design a clinical trial, I wanted to have a very nice, concretely designated gap in knowledge, so that after I publish this, I can say we are doing this clinical trial for the purpose of filling those gaps. Because I have to emphasize that this pathology, this acute or chronic liver failure, is extremely dangerous but very poorly understood. So we definitely need some original research as well, but in many cases, we don't even know where to start. Thank you.
Let me go back to this glucocorticoid issue. So which society has published guidelines and where?
This is the Enhanced Recovery After Surgery Society, 2016 guidelines. And this is the liver surgery guidelines.
And the journal is?
I don't know.
My thinking would be to submit your review meta-analysis to the same journal. In cover letter state specifically, okay, these are the guidelines, this is the meta-analysis that we think with new data is different, you should reconsider your guidelines.
That's a very good idea, thank you. Yes, because so far I have only used their own website to see their guidelines on different types of surgeries, but never went to the journal that actually published them. So this is thank you. It's a good idea.
If they will find this relevant, they'll publish.
Thank you.
They'll definitely go for it. If they'll find not so good, then I don't know what will happen. So it was which one?
World
World Journal of Surgery published that with an impact of 2.6 and like, I don't know where. Okay.
But I'm very happy that I have a whole committee who is helping me with the publication strategy.
Okay. Now the second one, you focused mostly on bilirubin. Is that the best marker that you could think of, or the one that is most frequently reported,
So, in all honesty, a meta-analysis is only good as the eligible articles.
Yeah.
And here we have an outcome that is regularly checked, followed up, cheap to monitor, easy to interpret.
Okay.
And that's why most of the literature that is available is using the bilirubin as some kind of a, not exactly, but some kind of a surrogate outcome for liver performance. Of course, there can be better ideas, and in my amateur idea, I'm not a specialist, but in my amateur idea, I think it's always better to have a big picture, because liver is responsible for so many different systems that only by having a larger picture about the whole homeostatic balance, we can say something about how the liver is doing, and not by putting these like GFR for kidney function. No, it should be a big picture, in my opinion.
Okay, you have a point there, but did you compare different markers that are almost always checked? At least 4 or 5 are almost always checked when we think there is something wrong with the liver. Or consult a gastroenterologist or somebody.
So here's the problem. There are many different markers that I wanted to check. So like the liver enzymes, the ALT, AST, an inflammatory marker, interleukin-6, CRP, and also prothrombin time. But the way that the articles in the literature report these outcomes is, first of all, very heterogeneous, both in the follow-up and also in the methodology of the measurement. So which result of bilirubin are they reporting, for example? Is it the peak? Is it the 2 hours after surgery? Is it the average of the day? What is it? Very heterogeneous. And also the measure itself. Most of them had either mean or median, but they didn't all have means or all have medians. And when that happens, we would need to convert means and medians between each other. But for that, we would need to have a very good idea about how the data is dispersed. And this distribution was not readily available in the literature. So that's why here we report on what the literature is talking about when it comes to different markers of liver performance, but we did not meta-analyze this.
What I'm amazed with that, you may say that the older trials, okay, they didn't know what they're doing, but the more recent ones, they are checking only bilirubin. And I don't see any data for gamma GT, which most likely is more specific and better because it's usually reacts to hypoxia.
Could be. Okay. But again, these are papers from surgeons. Of course.
Regarding your first topic, you said that maybe the failure is immune system mediated thing, as I
could be. Yeah, that's one hypothesis.
What do you think? Could you reject that hypothesis because you proved that the steroids didn't affect on the?
No.
No.
Okay. Because steroids is, when it comes to immunomodulation, steroids is basically like throwing a rock at a car to stop it. Yes, it can help, but it's very crude and sometimes it's not very effective. But here, this is a balance between availability of the drug and how familiar we are with it in the clinical practice. So basically, as my supervisor told me once, that we are trying to have a golden egg, basically, with the steroid story. Because if it turned out that it was clinically and statistically very sound, very reasonable, then we would have a virtually ubiquitous drug. It's on the WHO list of essential medicine, every veterinary clinic, every pharmacy has this drug, and it prevents people from dying. That would be fantastic. But unfortunately, reality is more complicated than that. And so therefore, even with these results, I wouldn't make any concrete authoritative arguments about the relationship between steroids and immune modulation, because the story is much longer than that.
And are you thinking about to use other immunosuppressant drugs to silence the immune system? For example, I don't know, anti-interleukin 6 inhibitor, or for example, I don't know, beta depletations drugs or something else?
Look, in the future steps of my career, this might be an interesting research question to ask. But with these studies, and these are my first author papers, my priority was not to illuminate the whole scientific community, but rather to be involved in the scientific process itself. So that's why I chose this let's move back from the policy and the guideline to see if it works approach. So it's not really absolutely about the research question, it's about research and science more in general. But in the future, possibly, someone who's smarter than me can do it.
Thank you so much.